Welcome to everyone. We are here for the symposium on the clock strikes innovation in CLL. As you may understand from the subtitle, we are going to talk about upfront care of, with newer time-limited BTKI combinations. And I'm Paolo Ghia from Milano, and I'm joined here today by Lydia Scarfò, also from Milano, and Matt Davids from Dana-Farber Cancer Institute in Boston. And we start thanking Peerview for organizing the event and AstraZeneca for unrestricted educational grant. There is a pre-event survey that we would like you to complete. There will be one at the end of the event as well. And please also be aware that we were going to throw a number of polling questions. So we want you to be ready and willing to answer, because that will make the symposium more interactive and more interesting for everyone. And we are going to show you in a minute the QR code that you can scan so that you can have access to the polls and the answers and the responses. And also there you could provide questions when you have questions that will be addressed during the Q&A session. That's for the people in the room. We have, fortunately, also people online, and the procedure is completely different, but again, they also will have access to the polling questions, and they will have the possibility to ask questions, but it's much easier probably, and you will find everything on your screen, and the chat is the way how you could ask for questions. Having said that, as I said, this is the QR code, so please take a few seconds to scan it so that you can respond to the polls and submit questions. It will be coming up regularly on the different slides, so don't worry if you don't make it now, or also for the people who will come in later. So again, this is the website in case you want to access, where you can find also the slides that can be downloaded at the end of the event, plus a number of documents and files that you can you will find useful. So the goals for today, as I said, the topic is BTKI BCL2 combination, in particular the new development and a new advancement. And we will see how indeed nowadays we know that the time limit treatment in general, and also the BTKI BCL2 combinations, are part of all guidelines and probably are becoming the preferred choice, both in the guidelines but also by all of us as physicians. And we will learn and discuss how we can personalize the use of the different combinations that we have, and in particular that we have always, as usual with all therapies, but in particular with the novel therapies, we have to find the best way to improve and maintain adherence to the therapy, because if our patients don't get the therapy, of course they don't get any efficacy. So the aim is always that when we decide about the best treatment for each single patient, we have to maintain them on that treatment for the entire duration. Having said that, again, I'm Paolo Ghia from Milano, and I will be doing an introduction to the main talks by Lydia and Matt. And the introduction is Challenges and Therapeutic Innovation for Treatment-Naive Patients with Chronic Lymphocytic Leukemia. So we start immediately with a polling question, and please review. We just want to understand how you see the field of time-limited treatment, in particular BTKI BCL2 combination. Meaning that, do you have access or not? Do you use it or not? Do you suggest them or not? So the first option, I rarely offer patient time-limit therapy in general. So you are, for many reasons, practical reason or philosophical reason, against the time-limited treatment. I don't use it because I don't have access. Second option, I don't have access to BTKI BCL2 inhibitors. That could be still in the US, maybe, possibility of not having access, and maybe you use only venetoclax or obinutuzumab. And then 3, 4, and 5 are the different combination. You offer venetoclax, enoblutuzumab or ibrutinib venetoclax. You offer venetoclax, obinutuzumab, ibrutinib venetoclax, or acalabrutinib venetoclax combinations, or you offer venetoclax, obinutuzumab, and acalabrutinib combination, or even more, you offer all of them, and you even think of using MRD-guided treatment. So having said that, are we going to see the results now? Here we go. Okay. So, yes, so probably there is a ex-US audience now. 52% are offering VenG and ibrutinib plus venetoclax. As we know, the ibrutinib venetoclax is not approved in the US, while instead it's widely used outside the US, in Europe and many other countries. There is, again, 15%, 16%, almost 20% of people who are using AV combination, either together with all the others, or only offering venetoclax or obinutuzumab. And then almost 15% of colleagues are thinking or using MRD in their practice, which is interesting. Of course, 20% of patients, or 20% of physicians here appear not to have access, or they don't really, they are not keen on using time-limited treatment. Maybe we will see if at the end of today they will change their opinion. Okay, so we can move on, I think, and I still see people coming in. There will be, for the people who just came in, we will have polling questions. There will be a QR code coming up, so you have just to scan it and answer the polling question. And also through the same system, you can submit questions. So as I mentioned already, time-limited treatment is becoming somehow the first option, preferred option in all guidelines, in particular here in the ESMO EHA European guidelines. If you scroll, the first option that is proposed is venetoclax obino, ibrutinib venetoclax, venetoclax obino, for the vast majority of patients as a first option. Not, of course, for patients with deletion 17p and p53 mutation, though also there the field is changing, and we will be talking about that. If we look at the German guidelines, the situation is a little bit more fluid, I would say, meaning that in patients with mutated immunoglobulin genes, definitely the first option should be also for the German time-limited treatment, including BTKI, BCL2 combination. And for unmutated patients, all options remains on the table according to the German colleagues, so they put at the same level time-limited treatment and fixed duration treatment. So we can discuss about that, how we can decide. And in particular for patients with deletion 17p and p53, again, a continuous treatment remain the first option. If we move to the US, these are the NCCN guidelines, and it's always more difficult to understand the priorities in the NCCN guidelines, because they are just typically proposing all the options that are viable for patients with CLL. They are not really giving a ranking, but of course there are time-limited treatments here, as well as continuous treatment that are available for patients with in front line. The good news, I think, for all our patients is that with time, and this is work by Matt and other US colleagues, with time we do see a decrease in the use of chemoimmunotherapy and an increase of the use of BTKI and BCL2I, and the combination with anti-CD20 as well. So as I say, this is good news, because all studies, and we will be seeing some of them, and we have already seen today during the morning session, chemotherapy is always inferior, at least in terms of PFS, in some cases, in some studies also in terms of overall survival, when it is compared to any novel therapy, monotherapy or combination therapy. As mentioned, we are going to also try to discuss and dissect the profile, the patient profile that can be better treated with one treatment or another treatment, with one combination or the other combination, because again, having so many effective treatments, it's becoming more and more difficult somehow to decide about the therapy, because it's not only about efficacy, they are all working well. I always say that we never make a mistake nowadays. Whatever we decide, we will get a response and the patient will feel better for some time. But it's really, here is really the idea of optimizing and finding the best therapy for each patient. So we have to consider always also the genetic features of the disease, and that we know since a long time, immunoglobulin gene status, P53 status. We have to still consider which patient we have in front of us, so age, but maybe fitness, but in particular comorbidities. Now we know that rather than age, is really the comorbidity profile of the patient, and also the drug profile. So we have to know exactly what we can expect from each single drug, from each single combination, so that we can find the best fit for every patient. And this is somehow summarized, the difficulty, I would say, of this decision is summarized in this table, where with the color code, Eugen Tausch and colleagues tried to give really all the nuances of the decision that we have to take for our patient. The list of drugs here is not complete. For example, we don't have the acalabrutinib combination because it has been just only recently approved in the EU. But it's just to tell you that we have to consider more of all these aspects, and again, there is not a green light or a red light that is absolute, but it's in every patient, considering the renal function, considering the reason of starting the treatment, considering the age, the fitness, and so on, then we can find the best fit for each of them. Having said that, now we move to Lydia, and who will be talking about the first steps with finite BCL2 BTKI options. Thank you very much, Lydia.
So thank you so much. Thank you, Paolo. I suppose I'm here representing the European perspective on the combination of BTK and BCL2 inhibitors. So I would like to start by highlighting that from a preclinical standpoint, it makes sense to combine BTK inhibitors and BCL2 inhibitors. As we know, the effect of BTK inhibitors on the lymph node microenvironment is very valid, and they are able to mobilize CLL cells from the microenvironmental niches into the peripheral blood, where they are more vulnerable. And we know that venetoclax is very effective in clearing the peripheral blood and the bone marrow. So starting from the preclinical rationale of combining these two agents, recent study applied this combination, and ibrutinib as first in class was of course the first one to be combined with venetoclax in young fit patients, and we have the results of the phase 2 Captivate study, and in a phase 3 randomized trial, the GLOW study, enrolling elderly and or unfit patients. So the first very practical advantage in combining these two agents is actually related with the reduction of the TLS risk, meaning that after covalent BTK inhibitors lead in, either through 2 or 3 cycles, it depends on the agent, the disease burden is rapidly reducing. So at the time of venetoclax initiation, actually the vast majority of patients showed low or intermediate risk of TLS, and this is greatly improving the logistic, as it does not require a hospitalization. Coming to the efficacy, in this group of patients treated with ibrutinib plus venetoclax in first line in the Captivate study, we are now accumulating long-term follow-up. And we here see that at 5.5 years, the progression-free survival is very reassuringly 66% if we consider the pooled population. And this is translating in a very favorable overall survival curves, where you see the 97% of patients, luckily enough, are still alive after 5.5 years. So of course we want to understand the biological feature associated with prolonged disease control. As expected, patients carrying mutated immunoglobulin gene are following a very favorable disease course, and here you see very high progression-free survival at 5.5 years of more than 80%. Also, patients with unmutated immunoglobulin genes are achieving prolonged disease control, and they fare even better if at the end of the combination treatment they achieve undetectable MRD status, as you can see on the right. And this analysis is actually focused on patients carrying unmutated immunoglobulin genes without TP53 aberration. Nowadays, I'd say that probably patients carrying TP53 abnormalities remain the high-risk subgroups we want to improve the outcome of. And here you see that again in the Captivate study, at 5.5 years of follow-up, 36% of patients carrying TP53 aberrations were still free from disease progression. And again, if at the end of treatment they achieved undetectable MRD status, the progression-free survival is longer, and they reach around 50% of progression-free survival at 5.5 years. This meaning on one side that we can use MRD as a sort of dynamic marker of disease response, but that we can also consider, and we have data from the FLAIR trial, to tailor treatment duration based on the MRD status. And here you see the recently published analysis of the study where they enrolled, again, young, fit patients without 17p deletion, and compared the outcome of these patients randomized to I plus V, ibrutinib, or FCR. And very interesting to note, the combination of ibrutinib plus venetoclax was able to achieve an impressive 94% progression-free survival at 5 years. That was statistically significant, together with an overall survival benefit compared not only to chemoimmunotherapy that, as mentioned, we are not using anymore in this setting, but also to ibrutinib monotherapy. Coming back to data in the elderly and fit population, the GLOW study has been updated with more than 5.5 years of follow-up. And the benefit of the combination of ibrutinib plus venetoclax in terms of progression-free survival was confirmed compared to chlorambucil plus obinutuzumab. That won't be anymore, hopefully, a comparator arm in the next trial we are going to design. But from a clinical standpoint, what is very relevant, of course, in the management of this patient is the time to next treatment. And here you see that only 20% of patients, regardless of the immunoglobulin gene mutation status, basically required a next line of treatment at 6 months of follow-up if they were treated with a combination of ibrutinib plus venetoclax. So what about safety? Because of course it is a relevant point in the management of our patient. In this slide you see on the left the tolerability profile, especially in terms of adverse event of interest in the GLOW study, where, as you can see, the median age of patients enrolled into the trial was 71 here. And you see that about 12% experience grade 3 or higher infections. And in terms of atrial fibrillation being one of the focus of the BTK inhibitor toxicity profile, more than 14% experienced any grade atrial fibrillation. On the right, instead, you see the tolerability profile of younger and fitter patients enrolled into the Captivate study with a median age of around 60 here. And grade 3 or higher adverse events, including neutropenia and hypertension, were generally very manageable. And in terms of the infection, I'd say this is the Achilles heel of patients diagnosed with chronic lymphocytic leukemia, so the infection rate is within the expected range. And only few patients experience cardiovascular toxicities. In terms of on-study death, if we focus on the events that occurred in the GLOW study, we see that while on treatment, 4 patients experienced cardiac or sudden death. But it's worth noting that in the patients randomized to the chlorambucil plus obinutuzumab arm, they had 13 post-randomized treatment deaths related to the infection. So this further supporting the risk of infections in patients receiving anti-CD20 monoclonal antibody. That said, today we are focusing on BTK and BCL2 inhibitor combinations, but I think that in terms of treatment choice, the jury is still out until we get the results of the CLL17 trial, where they are comparing ibrutinib monotherapy until intolerance or progression, the combination of venetoclax plus obinutuzumab, and the combination of ibrutinib plus venetoclax, and we hope to see the results very soon. So the last point I want to discuss during my talk today is the management at the time of relapse, because we learned from the initial studies that patients on continuous BTK inhibitor may develop BTK mutations that are associated with resistance, and so it was rational to test the presence of the mutations in the patients relapsing after I plus V combination. And here you see the initial analysis that was performed when we had about 3 years of follow-up. 29 patients progressed after ibrutinib plus venetoclax, but none of them was carrying at the time of relapse BTK or PLC gamma 2 mutations. And this was very comforting, of course, in terms of the possibility of using the same class of agents at the time of retreatment. More recently, the updated results were presented. We have now 64 patients who progress on ibrutinib after ibrutinib plus venetoclax treatment. And again, no BTK or PLC gamma 2 resistance mutations were identified at the time of progression. A couple of patients at the time of progression were carrying BCL2 mutation, but not the standard mutations that is associated with clear resistance to venetoclax. And indeed, one of these patients didn't even require treatment initiation, and the other one achieved a partial response on fixed duration treatment. So along this line, when we analyze the overall response rate in the whole cohort, we have the data on about 25 patients treated with ibrutinib single agent and 11 patients treated with a combination of ibrutinib plus venetoclax. Per protocol, patient could be retreated with a fixed duration I plus V only if they had experienced relapse at least 2 years after completing ibrutinib plus venetoclax treatment. And in both cohorts, you see that the overall response rate was very high, around 80%. Of course, the follow-up is shorter for patients treated with ibrutinib plus venetoclax, but the 1-year PFS and overall survival rate are 100%, and in those treated with ibrutinib monotherapy, the 2-year PFS and overall survival are still very high, 91% and 96% respectively. So are we ready to use these combinations in the clinical setting? I just say we are, and we are currently using, but in the future, can we improve the results by adding the anti-CD20 monoclonal antibody? We will discuss definitely in more detail later after Matt talk, but here I'm showing you the results, the updated results of the Ghia trial, where with a 5-year follow-up, we can see that in terms of progression-free survival, there is a benefit of the triplet compared to the combination of venetoclax plus obinutuzumab, and this benefit is particularly relevant in patients carrying unmutated immunoglobulin genes. And with this, I would like to conclude by asking you to rethink your choice. So we are giving you a possibility that you rarely have in life, think again about what you want to do, and based on the current evidence, what is your opinion of downstream resistance and retreatment after first-line therapy with time-limited BTK inhibitor venetoclax regimens? And I'm reading again the option. 1, I am unfamiliar with current evidence on resistance retreatment. 2, I won't consider retreatment because resistance mutations are likely to be common. 3, I would consider retreatment only if relapse occurs after at least 12 months. 4, relapse after at least 24 months. Or 5, I would consider retreatment regardless of the duration of disease-free remission. So please vote. I don't ask to the other panelists because I don't want to spoil the results. Okay, that's very interesting. We could probably discuss what's the best threshold. I see the majority is considering the possibility of retreating patients, and there is actually a little bit of discrepancy between the 12 months and 24 months. I don't know, Paolo and Matt, if you want to comment on this.
Yeah, I mean, I think that, can you hear me?
No.
No.
Can we put the microphone on? Yep, there we go. I think that I would certainly consider retreatment. I think we have options, of course. We just saw we could do single agent BTKI continuously or another round of time-limited therapy. So for me, the duration of that initial remission would influence that. Specifically, if I had a very short relapse after the frontline time-limited therapy, I'd probably use continuous therapy after that. Whereas if I had a longer initial remission, say more than 24 months, I might be thinking about a time-limited therapy again.
So Paolo, why did you put 36 months in the ESMO guidelines?
That comes exactly as it was before for chemoimmunotherapy, just a discount. But I think that this is a very nice bell-shaped curve, meaning that some are prone to use it after only 12 months, many more 24 months, and some are also considered regardless the duration. I have difficulties. The data is not clear, it's not out there. Why not to try again a time limited? I understand the 19-20%, 1 out of 5 that is considering regardless, because again, it depends also on the type of relapse, on the velocity, so on and so forth. So why not to try in the worst scenario, you keep on treating and you go on with the continuous treatment.
And maybe genetic markers influence this too. If you have TP53 aberration, maybe you're more likely to do continuous therapy.
So thank you so much. And now I leave the floor to Matt. Thanks.
So we have now Matt Davids, as we said, from Dana-Farber. We'll be talking about the new wave of time-limited BTKI-based combinations. Thank you, Matt.
Great, thank you so much. So we, of course, have more selective BTK inhibitors now that represent this new wave of time-limited therapies. So just to briefly review the data from the head-to-head studies, we know now from 2 phase 3 trials that the more selective BTK inhibitors are superior to ibrutinib when it comes to toxicity. As you see on the left with the ELEVATE-RR study, there were significant advantages with acalabrutinib with respect to lower rates of atrial fibrillation, hypertension, and all-grade bleeding events, with no decrement in terms of progression-free survival, which was non-inferior. With the Alpine study, we also saw a significant improvement with lower rates of atrial fibrillation with zanubrutinib compared to ibrutinib, although similar rates of hypertension and all-grade bleeding events. But interestingly, in the Alpine study, we also saw an efficacy advantage of zanubrutinib over ibrutinib with respect to PFS. So going back to the early days of these drugs, acalabrutinib and zanubrutinib, we and others began to ask the question of whether these should be combined also with venetoclax in time-limited regimens. And the first phase 3 trial to look at this is Amplify, which you're probably familiar with, so I'll just review it briefly. These were previously untreated CLL patients without high genetic risk, so no deletion 17p or TP53 abnormality, and they were randomized in this 1-to-1-to-1 fashion to acalabrutinib with venetoclax, either with or without obinutuzumab. And in both of these regimens, these are fixed duration of 14 cycles of acalabrutinib and venetoclax. And these were compared to a control arm of chemoimmunotherapy with a primary endpoint of progression-free survival comparing the doublet, AV, to chemoimmunotherapy, but key secondary endpoints looking at the triplet versus chemoimmunotherapy, and then also investigator assessments. This is the primary outcome, which showed superiority of AV over chemoimmunotherapy and also AVO over chemoimmunotherapy, with significant hazard ratios in favor of the AV-based therapies. The study was not designed to directly compare AVO to AV, although you do see those curves separate a bit as you get to 36-month PFS, which is intriguing. And I think an important message from this study also is that there was a benefit for the AV-based regimens over chemoimmunotherapy regardless of age. So you can see at the bottom whether patients were under the age of 65 or older, there was still a hazard ratio favoring AV-based therapy over chemoimmunotherapy. I will note that the AMPLIFY was a relatively young patient population. Median age was 61. Now, the biggest difference for these AV-based regimens was clearly seen in the IGHV unmutated group. You can see that at the top, where there was significant separation of the curves, both in terms of the AV regimens versus chemoimmunotherapy, but also the AVO versus AV, which again is not a powered analysis, but I think it is intriguing to see that benefit. With 3 years of follow-up, you don't see any significant difference in progression-free survival in that mutated IGHV group. Although I will caution you that 3 years is still a little bit early to look for a frontline CLL trial, so with longer time, I think it will be interesting to see if a PFS difference emerges even in the mutated IGHV group. Now, Paulo led a more detailed analysis of rates of undetectable MRD that was presented at the EHA meeting recently from the AMPLIFY study, which I think was very illustrative. We saw about a 30% rate of undetectable MRD in the blood at 10 to the minus 4 with the AV arm, but it was clearly higher at 65% with AVO and sort of in the middle with chemoimmunotherapy at 51%. In the graph here, you can see the kinetics over time of attaining MRD in the blood, with the reddish color representing detectable MRD and the green undetectable MRD. So with AV, you do see it come up relatively early into that 30% range, and it's maintained pretty well even off of therapy for 2 to 3 years. With AVO, you see achievement of undetectable MRD much earlier. See that first green bar, and then it's maintained even off therapy. So I think it really does speak to the power of a triplet regimen in achieving undetectable MRD. Now, safety also is an important concern, and I think particularly with the AMPLIFY study, it was illustrative in terms of the addition of the CD20 antibody does seem to increase the risk of more significant infections, particularly with COVID-19. So if you go to the bottom of this slide, you will see that there were 5.3% of patients with death due to COVID-19 in the AVO arm, which was even higher than chemoimmunotherapy and higher than AV. Now, this has been analyzed in a very detailed fashion because of the timing of this study, which did occur during the height of the COVID pandemic, and some of the patients who died due to COVID had not had access to vaccines yet. So I think we need to continue to generate additional safety data, particularly with the AVO triplet now that we have COVID vaccines and treatment. The other thing that was very striking to me about this study was the very low rates of atrial fibrillation and hypertension in the AV arms, sort of in the 1% to 4% range. I think this speaks to the advantages, not just of the BTK inhibitor being more selective, but also a time-limited therapy. So with both of these, even patients who have cardiovascular comorbidities can be considered for these therapies due to the low rates of cardiovascular toxicity, and we did not see any sudden cardiac death signal in the AV-containing arms. So based on sort of initial results and the very strong preclinical rationale for AV combination, the MAGIC study opened a couple years ago and finished accruing about a year and a half ago now. This is a frontline population of all comers that's comparing the AV doublet to venetoclax obinutuzumab in a non-inferiority design. One of the unique aspects of MAGIC is that both arms of the study are MRD guided, so all the patients get 12 months of the venetoclax combination, and then, of course, ven-obin is the 6-month combination with 6 months of venetoclax monotherapy. And after that initial year of therapy, patients have an MRD assessment that's done by the adaptive clonoSEQ assay. And patients who achieve 10 to the minus 5th or less undetectable MRD stop therapy. Those patients who still have residual MRD go on to get a second year of venetoclax-based therapy. With AV, they get the doublet for 1 more year. With the ven-obin, they get a second year of venetoclax, and then all patients stop at the end of the 2 years of therapy. So we don't have any data yet from MAGIC. It's still maturing, but we think this will hopefully be informative. We've also done a phase 2 study of the AVO triplet where we enriched the population for patients with high-risk disease. So this was also an MRD-guided strategy with a similar approach, in general 15 or 24 cycles of AV-based therapy with the initial 6-month obinutuzumab combination. And we had 72 patients total in this multi-center phase 2 study. We looked at the overall population and compared that to the patients with TP53 aberration, which was about 45 patients in this study. And when we looked at the rates of CR with bone marrow undetectable MRD at the start of cycle 16, they were identical in both groups, 42%. You can see the response rates deepened over time on the left with the patients with TP53 aberration, and on the right in the overall population. And if we looked at 4 years for PFS, the rate was 70% in patients with TP53 aberration. Now, we've seen in other studies a median 4-year PFS with venetoclax obinutuzumab in this high-risk population. From the Captivate data set, it looks like it's probably about the same, a median 4-year PFS. So here, 4-year PFS is 70%. I will note that here, the patients did receive often more therapy. They got a second year of treatment, whereas in the CLL14 and Captivate, it was the 1 year of treatment. And also, it's difficult to compare across studies. But we do think that this is still a promising regimen for the high-risk patients. And I think going back to the mention of the toxicities in the Amplify study, here in a study that was done mostly post-COVID, but did include some time during the COVID pandemic, in the US, we saw also a favorable safety profile with 1 COVID-related death in the 72 patients. And again, no ventricular arrhythmias. There were no significant bleeding events on this study. And again, low rates of atrial fibrillation, about 6%, and hypertension, 11%, suggesting that this triplet-based therapy is well tolerated for many patients. So we do need more randomized data, I think, to better understand what the role of these next-generation triplets will be in the disease. And the CLL16 study will help provide evidence for this in the high-risk patient population. This is a study being led by the German CLL study group that is still actively accruing, and it's randomizing patients 2-to-1 to AVO triplet versus venetoclax obinutuzumab. And this study does allow acalabrutinib maintenance in patients who still have residual MRD at the end of treatment. Now, there's also very promising combinations with zanubrutinib and venetoclax. The BOVEN study is a triplet with zanu, ven, and obin, led by Jake Sumerai at Mass General Hospital. This was originally 39 patients, and this study did not enrich for high-risk features, but about 13% of patients were TP53 aberrant. And you can see very high rates of undetectable MRD, 96% in the peripheral blood, 92% in the marrow, and very rapid achievement of undetectable MRD, as you can see in the graph on the right. And patients on this study had, in some cases, just a relatively short course of about 9-10 months of therapy, and were able to maintain MRD at long-term follow-up. So as we look to the future of zanubrutinib-based therapy, the Celestial TN study is looking in a frontline population at zanubrutinib with the newer BCL2 inhibitor, sonrotoclax, comparing that to the standard of care, venetoclax obinutuzumab, with a primary endpoint of progression-free survival. And this study does include patients with high-risk disease, which I think will be helpful. And the study, I believe, is fully accrued now, but we're waiting still for data. I also wanted to touch briefly on retreatment with second-generation BTK inhibitors after time-limited therapy. We do have more limited data here compared to what Lydia showed you, but we have some. From our AVO triplet study in the US, we have 5 patients who have relapsed. 4 of these 5 patients did respond to retreatment. 1 patient at this time had not yet been evaluated, but clinically was responding. And then the HOVON 159 REVEAL study has presented some data for retreatment after frontline ven CD20-based therapy. And these patients are then treated in the second-line setting with 24 cycles of acalabrutinib venetoclax with a primary endpoint of bone marrow undetectable MRD at the end of treatment. And from this very early analysis they just presented at EHA, there were 15 evaluable patients, and 21% had already achieved undetectable MRD in the bone marrow. And all of the patients had achieved IWCLL response with no significant issues due to toxicity. And as we look to the future, we're going to have a lot of patients from the MAGIC study who will eventually relapse off of AV, and we want to capture those patients in a prospective trial. So here at this IWCLL meeting, I'm presenting a trials in progress poster with the design of a new study that has not opened yet, but will open hopefully soon, and this is called MAVERIC. MAVERIC stands for Mutation-Guided Finite Duration AV Relapse after frontline finite covalent BTKI plus venetoclax. So the idea here is a phase 2 study to retreat patients who previously had BTK-BCL2 combo, broadly defined, so it could be ibrutinib, could be acalabrutinib or zanubrutinib, and to treat them here with acalabrutinib plus venetoclax as a doublet. But unlike many studies which are using MRD to guide therapy duration. Here we're actually using IGHV mutation status to guide therapy duration. Maybe we can get into this a little bit in the discussion, but not in terms of the rationale. But in this study, patients with mutated IGHV will get 1 year of therapy and then stop, regardless of MRD. Patients with unmutated IGHV would receive 2 years of therapy and then stop, irrespective of MRD, which will, of course will be tracked, but will not be used as a decision-making point. And the primary endpoint of this study will be overall response rate after 12 cycles of combination therapy, so that hopefully we can get a fairly rapid readout to get an initial sense of the activity of this combination in the retreatment setting. All right, so our last polling question for the first part here. Which statement now matches your understanding of the evidence with time-limited second-generation BTK venetoclax doublets and triplets in treatment-naive CLL? So please answer. Your choices here include that doublets are effective, but triplets are likely overly toxic. Doublets and triplets are effective, but do not induce deep MRD-negative remissions. Doublets and triplets are effective. Triplets can induce deep remissions, including in higher-risk CLL. Or doublets and triplets are effective. Triplets can induce deep remissions, but not against higher risk CLL. Looks like about 3/4 are saying that the doublets and triplets are effective. The triplets can induce deep remission in higher risk CLL. I agree with this. There's still some hesitation in terms of the triplets and toxicity. About 15% think that the triplets may be overly toxic. So interesting. We'll discuss.
Fair enough.
Thank you.
Okay. Thank you, Matt. So we start now a couple of cases, and I will try to embed in our cases also the question that we have been receiving so far, so please keep on asking, and we will try to answer to every question, if not specifically, but in the general discussion. So here, so we try to identify a typical patient for which we would choose time-limited treatment or a continuous treatment, and which type of time-limited treatment. So, and that's, we received already 2 or 3 questions regarding exactly what is the profile of patient where we would go for a certain time-limited treatment or not. So here we have a 62-year-old man, so what we would consider still a young patient that needs to be treated due to anemia due to the bone marrow invasion. Well-conditioned, no major comorbid illnesses. From a genetic standpoint, a mutated immunoglobulin genes and a deletion 13q at FISH, no deletion 17p, neither mutation in p53. So let's start discussion. Is this the typical patient where you would prescribe only time-limited treatment? What do you see? Lydia.
Leading questions, but I agree, meaning that I think this is a relatively easy patient, meaning that even chemotherapy would work in this setting, but of course we want to avoid the potential toxicity, and we now know that novel targeted agents are definitely better. But I just say that this is typically the patient when you get nervous because he is young and you want to assure a 20 years at least of overall survival. And the best way to achieve this goal, I would say, is to choose a fixed duration regimen so far available. I would discuss with this patient both options we have available as a fixed duration regimen, either venetoclax obinutuzumab and ibrutinib plus venetoclax or acalabrutinib plus venetoclax, because nowadays is available in Europe, though not in Italy yet. And I do not see the benefit of adding the anti-CD20 in this specific setting, so that's to the combination of a covalent BTK inhibitor plus.
So no particular preference between VEN-G or BTK-IBCL2?
While waiting for the results of the CLL17, I would discuss both options with the patient.
Matt, in the US?
So I would prefer VEN-G for this patient, mostly based on the long-term follow-up.
That's the only one that you have available.
No, I mean, we can use the other regimens. I would consider ibrutinib venetoclax for this patient. It would be off-label use in the US, but this patient doesn't have cardiac comorbidities, and he's young, and we've seen great long-term data also from I+V. But my own default would be VEN-G. In the US, though, this patient would typically be treated with continuous BTKI in most community practices. So it's very different in the US in the academic versus community practice.
So the easiness of administration is really taking over all the other aspects. So.
That's right.
Okay, so we go to second case, Lydia. No, it's Lydia or Matt?
So it's Leila, 73-year-old woman with this time unmutated immunoglobulin genes, and I understood that the reason for progression is more or less the same, so it's anemia, hyporegenerative anemia, and this time we have to take into account hypertension and hyperlipidemia, so she has a comorbidity profile. So I just say with unmutated immunoglobulin genes, I'm still considering both a combination of BTK inhibitor plus venetoclax and continuous BTKI. And I would probably discuss taking into account also the logistics, the care partner. I mean, I'm not scared of hypertension and hyperlipidemia. I think these are manageable, especially if we optimize concomitant medication and follow-up before starting treatment. So I think both options can be considered.
And would you make a difference between the BTKI?
I mean, I know we have limited data in patients older than 70 years. Actually, the majority are those derived from GLOW, but if I had available probably the combination of acalabrutinib plus venetoclax, translating the better tolerability profile we saw in young patients, and we saw when it's used as monotherapy, I would probably go for acalabrutinib plus venetoclax.
In the US?
I would still probably go for Ven-G for this patient for the same reasons.
Boring.
I would expect a shorter PFS than that first patient with the mutated IGHV. So I'm tempted to think about triplet with AVO here, but the follow-up is still pretty short from the Amplify study, 3 years, so it makes me a little hesitant. And I don't think I would use AV because of the unmutated IGHV with probably a shorter PFS. This is, again, a patient that would probably be treated with zanubrutinib or acalabrutinib by most community oncologists in the US, but I would probably still push for
probably
Ven-G.
also in some academic center, because it's really a gray zone where you might still want to have a continuous treatment. One question from home, let's say. Same case, but with atrial fibrillation under anticoagulation and EGFR of roughly 50. So how do you decide?
Well, EGFR of 50 is not so bad.
Not so bad.
Patient, right?
It was not so nasty at the end.
Right. CLL14 allowed down to EGFR of 30, I believe. So I would still feel comfortable using Ven-G, and those additional cardiac comorbidities would, again, push me away from a BTKI.
Okay.
I'm not excluding patients with atrial fibrillation, even if they are on anticoagulant treatment for BTKI-based regimen. So again, I think these are both feasible options, especially if the atrial fibrillation is permanent. I mean, you cannot develop additional atrial fibrillation. So I just say both options can be discussed. And Paolo, what if she was carrying a 17p deletion TP53 mutation? What would you do?
Yeah, that was also, there are a couple of questions also from home about this. How someone asking continuous treatment only for deletion 17p, or would you consider, another question, would you consider time limited for 17p? I have to say that every month I change my opinion. Meaning that 1 year ago I would have said definitely deletion 17p, p53, continuous treatment. That's what we have written in the old guidelines. Now I'm much more prone to think and discuss, depending also on patient preference, patient support to the time limit, if they are convinced they really want, if they are young. I would say that I would feel to propose it, because in the worst scenario, if you don't like the response or if you see that it's a little bit too short, then you can keep on restarting the BTKI continuous, and therefore you didn't lose much. Maybe this is the setting where we should start thinking using MRD, because in the Captivate study, which is one of the few studies where we use BTKI and BCL2 in deletion 17p patient, we do see that the patient who achieved undetectable MRD and they have deletion 17p or p53 mutation, they have a median PFS at 5.5 years of roughly 50%. While instead, if you don't achieve undetectable MRD, it's really like almost a vertical line. I mean, 30% of patients only will be free of progression. So I think that's probably the way to go. 5.5 years, 50% is not bad, even for 17p patient, and we don't expose them to the continuous pressure of the drug. So, as I said, I'm shifting little by little towards that. Okay, so now we have another polling question, and so you heard about the patient, 73 years old woman, a mutated immunoglobulin gene, comorbid with hypertension and hyperlipidemia, and what would you consider? Continuous BTKI, not convinced by the evidence of time limited, or because just it's simply more convenient. VEN-G, as Matt made the point. Ibrutinib venetoclax, because of the captive and glow. Acalabrutinib-based combination, even with Obino or without. And a gray area, everything is good, everything is bad, I don't know really what to do. I would go one of the time. So, indeed, it's a gray area, I would say. And so, it's true. Unmutated cases, as I said at the beginning, it probably remains a gray area, unmutated patients. Though, I think, again, patients with unmutated immunoglobulin genes, they have more DNA instability. Probably those are the patients that we don't want to expose too long to a therapy, because we are somehow selecting a worse clone. So nowadays, again, when I see unmutated patients, I think these are the patients where we should really give time-limited treatment so that we leave the disease untouched and we don't create more damages. But that's only my opinion, and maybe we leave it open. There were a couple of questions that now, because I mentioned before MRD. Would you use MRD? Or do you use MRD? I ask Matt, because sometimes they do.
Yeah, I mean, in the context of the AVO regimen, we've been using MRD based on our data set from our phase 2 study, but really sort of a limited MRD, 1 or 2 years of therapy. So we check it, and I think it's prognostic. I don't know that I would routinely recommend doing it in practice at this point. It's sort of more informing the response.
But in the future, and there were a couple of questions on that, when would you test Lydia, and how long would you go anyhow? Would you go until, like Pete Hillman did, until you get undetectable MRD, even if you don't get there? So.
I think in the future we will rely more on MRD. I think it's providing very relevant information in terms of the disease trajectory. I would say that probably we don't need to achieve undetectable MRD in every patient with CLL. Probably in patients with mutated immunoglobulin genes, there is no strict need to follow to achieve the undetectable MRD goal, but for patients with unmutated immunoglobulin genes, and then you mentioned for patients with TP53 aberration, it would be better to define treatment duration according to the MRD results. And indeed, this morning, also Dr. Jane mentioned that the duration of treatment was actually quite arbitrarily decided. So it might be that in some specific patients, the treatment duration may be prolonged in order to achieve deeper responses. As there are preliminary results suggesting that if you test MRD early, you can get an idea of the disease trajectory on treatment, I would say, because it's a peripheral blood test. I think now we are close enough to say that we don't need a bone marrow validation. I would do an early assessment in order to understand if the disease is responsive, and then probably at the time of the treatment end in order to define if I want to continue.
So, Matt, do you want to go through this case?
Sure. So this is case 3, which is similar to the last case, but a bit of a younger and fitter patient. So Simona is 64, has symptomatic CLL, presents with a performance status of 0, but Binet stage B disease with large, bulky, symptomatic adenopathy, so needs treatment. Is found to have unmutated IGHV, but no TP53 aberration.
So, are you leaning? Well, you were already. The panel was already convinced to use fixed duration treatment, but is the younger age an additional reason to really convince and talk the patient, say, look.
The question is actually, would you use Ven-G in this patient?
Still?
I would,
or you dare a little bit more?
Well, here I would consider the triplet a bit more as well with acalabrutinib because the patient has no cardiovascular comorbidities and she's a bit younger. Of course, we don't have head-to-head data yet for AVO versus VO, but I think that would be an option. I still like the long-term follow-up, though, with CLL 13, actually, in this case, would be kind of a younger patient would apply here. So, yeah.
So,
and I just say when the reason for starting treatment is the presence of bulky lymph nodes, the use of the BTK inhibitor is somehow very helpful in achieving a very fast disease control.
Yeah, that's a good point. With Ven-Oben, there is a shorter PFS with the bulky lymph nodes greater than 5 centimeters. That might push me toward BTK combo here.
So again, we're trying to define the profile because we had a couple of questions really asking what are the drivers of your decision. So now we learn about age, we learn about unmutated immunoglobulins, we learn about lymphadenopathy. So all these are helping to decide for a time-limited and also for a BTKI-BCL2 combination. Then we have also a nasty question, an interesting question from the audience. Same patient started AVO, whatever you want, a patient has adverse events and you want to stop it. Would you go to another fixed duration VG or you go to continuous BTKI? It depends on the adverse event.
Right. If it's a major bleeding issue, I'm not going to go back to a BTK inhibitor. But if it's something else,
so it's the type of adverse event that is really
exactly that's the key
guiding rather than okay. And another couple of questions regarding mutation, BTK mutation, PSC gamma 2 mutation. Would you consider them, should they be considered? What do you do?
I think nowadays we do not have yet solid data suggesting how to integrate the BTK and PLC gamma 2 mutation testing in our treatment algorithm. If I have to start testing this mutation, which is something I'm currently doing only for research purposes at my hospital, I would start with those on continuous BTKI treatment because for those on fixed duration treatment, as mentioned, only the BTK and PLC gamma 2 mutations were basically not identified. But for those relapsing on continuous BTK inhibitor, it might be that in the next future they are providing helpful information to inform our next treatment decision.
Yeah, I fully agree. I think one sort of specific scenario where it could be useful, for example, a patient progressing on a covalent BTK inhibitor with an L528W mutation, you may not want to prioritize pirtobrutinib as the next line of therapy since we think it's less active for that mutation. So it's not something that's in routine practice yet, but I think it's probably coming.
Okay, so now another question, another polling question. So this is the case, a young fit woman with the unmutated immunoglobulin genes, bulky lymphadenopathy, so let's keep that in mind. What time-limited option would you now consider? Any time-limited option? BTKI venetoclax doublet, BTKI Ven-G, so a triplet, MRD guided, or again, it's a gray area. We see what the patient says, how the weather is. Okay, 50% convinced of the doublet, 30%, yeah, fit, 64, I mean, what would you want more? A triplet, even MRD, it would be nice again to understand, yeah, until undetectable MRD, yes, why not? I mean, for a maximum of 2 years now, the British colleagues say, so don't push too much. If it doesn't get to undetectable MRD, it's fine. Okay, so this is a good thing. And now we can move on, and we can go to the conclusion. So we have seen these 3 cases, and we try to make the point. Mutated patients, I think they deserve to have a fixed duration treatment. It's really difficult to propose nowadays a continuous treatment for mutated patients. We are always over-treating them. Maybe we should even, now we have a study as ERIC, European Research Initiative on CLL, where we try to decrease the length of treatment, of time-limited treatment, to 6 months instead of 12 months, based on the velocity to achieve undetectable LD. So keeping that in mind. For unmutated immunoglobulin genes, again, is probably a balance between age, comorbidities, and the reason to start treatment. So it's the 73 years old patient may still benefit from time-limited treatment. Maybe with a second-generation BTKI, it's easier to deliver the treatment. In a young patient, the 3rd patient, definitely there, especially because of the bulky lymphadenopathies, is definitely a big driver of the decision. You achieve a quick response of the lymph nodes. The patient is relaxed. You don't have issues with the tumor lysis syndrome later when you add the venetoclax, and therefore you can go easily into completion of the BTKI BCL2 combination. And so this is we can do a summary, but you understood, already heard everything here. So it's the BTKI BCL2. We didn't speak about that. There is also a practical advantage. It's all oral, of course. You don't need to hospitalize the patient. You don't need to do infusion, in particular in the EU and other countries. To find a place in the hospital is always an issue. Of course, now with the 2nd generation BTKI, we can expand also probably the range of age and comorbidities that can be treated with time-limited treatment. Triplets remain under evaluation, I would say. Definitely we can find patients where we can effectively use them with no or limited risk. Of course, we have to consider comorbidities and age. So we already done this. You already asked a lot of questions. We answered. I want to go quickly through 3 of them. One is to Matt. What is the time to next treatment in your AVO study, if you know it?
Median not reached yet.
Okay.
So at 4 years, I think it's still about 80%.
Okay,
Yep.
Very good. And another thing is about other genetic abnormalities, ATM or anything. Are you using anything, or complex karyotype? Are you using any of these in your algorithm of decision?
I think they are not yet validated, so probably we have still to gather data, and not yet, let's say. Okay.
And with that, we can conclude. You can visit the site and complete also the post-test evaluation. The slides will be available, and there will be more events also in the future. Thank you for being with us, and have a great IWCLR meeting.